Good morning. I feel so privileged and honored to be able to do part 2 of the Roadmap to the Cure, where I'm going to review the ongoing and completed clinical trials for 2013. Now, I think Scott did a fabulous job yesterday laying the groundwork. I think everybody in this room who was here yesterday knows everything you need to know about CFTR. So I'm going to expect you to know all the slides. You'll see a few of the slides that are overlapped, but that's just going to be a reminder for you. Now, 15 years ago, I did this presentation. It was in Nashville. And at that time, it was really hard to figure out how we were going to fill an hour. So I showed lots of pictures of mountains and stuff. But this year is the totally opposite. There is so much going on that I want to apologize up front because I'm not going to be able to cover everything, hopefully anything, but everything. And if I don't cover an area that you're very interested in, it's just due to the limitation of time and not that we don't value absolutely all the clinical research that's going on. The last thing I want to say is yesterday Bob did his fabulous job of giving an overview, and I'm going to talk about how we're trying to get to 100% of patients. But he also mentioned streaming, and I didn't think too much about it. Last night I got some emails from some of my patients saying they were going to be watching me online, and that freaked me out. So I'm just going to say hi to you out there in the cloud. So I have to disclose that my capacity as the director of the TDN, I do work with many companies which are listed here, several I'll be mentioning today. So the dream of every person in this room is that all patients with cystic fibrosis will live full, healthy lives. And I hope I can show you over the next hour a roadmap of how we can get there. Now, yesterday Scott showed you that CFTR is a protein that sits right at the top of the cell membrane, and it's very involved in the balance of salt, water, and pH across the airway. And so it keeps that periciliary liquid level constant, and therefore you can have normal clearance of the lungs, which is shown by that big white hole in the middle. That's what we want, is a clear airway. Unfortunately, if CFTR is not where it's supposed to be in the cell, then you get dehydrated mucins and mucus, as you saw, and you get that very narrowed periciliary liquid level, and then you get the obstructed airway. That's what we're trying to prevent. So how much CFTR is it going to take? Scott ended on this issue. And both natural history studies, which you see here, which is will be coming out shortly in JCF, show that going from pancreatic insufficient to sufficient patients to carriers, there is a decrease in sweat chloride, and it's relative to the amount of CFTR function. And it looks like about 30% function. It's not perfect, but it's a benchmark we have right now, which is associated with decreased symptoms. And we saw that also with the ivacaftor studies, which I will discuss in a minute. So CFTR is made in the endoplasmic reticulum. It then goes up to the surface, and then it opens up and becomes a chloride channel if it's normal. We know that there's well over 1,000 mutations, and they are different functional classes that have been defined. Classes 1, 2, and 3, where the protein either doesn't get to the surface, or if it gets there, it can't be opened. These are the more severe mutations, and they're associated with pancreatic insufficiency and often decreased survival. The milder mutations, like 4 and 5, some CFTR gets to the surface, you get a little bit of function, and they often are pancreatic sufficient and have often a longer survival. Now, please remember that every patient has 2 mutations. Fortunately, if you have a milder mutation, it does tend to dominate. So looking at these different functional classes, it's clear that we're going to have different approaches. And we have 2 major approaches using small molecules that you've heard of before. So the first treatment approach is to have small molecules that help in the folding and trafficking of that protein and assembly in the cell surface. And those are called correctors. And we'll need them where there's little or no CFTR at the surface. The next group are potentiators. Now, these are gating therapies where it opens up the channel and allows chloride movement. Please remember that the more severe mutations are likely going to need both therapies. This data was taken from the 2012 U.S. CF registry, and it represents almost 26,000 individuals with cystic fibrosis for which at least 1 mutation is known and recorded in the registry. And I show it to you to see the complexity of our challenge of treating 100% of patients. The first thing you'll see, if you look at that bar on the left, is F508 clearly predominates. And it predominates so much that everything else looks like little tiny dots down there on the bottom. So we're going to change it to a log scale so that you can see all the mutations. And what we're going to try to show you is how we're going to cover all of these. Our first proof of concept for mutational specific therapy came with the class 3 mutations. As you remember, they get up to the surface, but they don't open up normally, or they don't have a normal gating function. Now, high-throughput screening was used to look at these large libraries of compounds in combination with medicinal chemistry. And through that, the initial hits were optimized to be more biologically active and to be better drugs. And through that process, they finally identified some key lead compounds, which eventually became VX770, that was shown in G551D epithelial cells to correct the chloride movement. And once this drug was identified, along with several other lead compounds, but this one was the one that was sent forward, the question was, how would it impact sweat chloride? And so there was a phase 2 study. Franco Curso was the lead author in 2010 that looked at a dose escalation to find out what is the optimal dose. And they found it was 150 milligrams twice daily. And with that, you got an improvement in sweat chloride of about 50 millimolar per liter, which ends up being our benchmark of about 30% activity. Now, what was really important is, that was a biomarker, but how does that actually impact the patient? And here we have both of the phase 3 ivacaftor studies together, the one in 6 to 12-year-olds and the one in 12 and older. And it shows you that there was a dramatic response, and lung function started at 2 weeks, was seen through 48 weeks. 24 weeks was where the primary endpoint was, and it was a 10 to 12% improvement across a wide range of illness severity and age. And even more exciting is now long-term open-label studies, as well as the GOAL study that you heard about yesterday. We're seeing a persistence in this change in lung function. No other therapy that's been developed has had this persistent of an effect. In addition, it's improved other health measures. This is actually from the GOAL study provided to me by Steve Rowe. And just like you saw yesterday that there may be an impact on Pseudomonas. We don't know fully yet. There's been a dramatic decrease in the number of hospitalizations, as you can see here, as well as weight gain and other quality of life measures. So this was very exciting. But I don't want everyone in this room to just say, oh, well, we developed Kalydeco. I think Bob told you yesterday that the CF community is now in a very special position, which is we have the tools to develop these life-changing drugs. And I just want to review the lessons learned so that we don't forget them. So back in 1998, the whole therapeutics development program was started, and the visionary for that was Bob Bell, and I think we need to understand the impact he has had on this whole program. But it started with high-throughput screening. Well, this looks like this machine, you dump some compounds out, and then at the other end, something called ivacaftor comes out. Well, it doesn't really happen like that. You got to figure out what the cell lines are going to be. These were immortalized cell lines that you're going to use to do the screening and what the screen's going to be. And that was an effort throughout this international CF community to develop those first screens. And after months, there were some good lead hits, and it was an iterative process with medicinal chemistry to find better and better hits. And so then the next question is, how are we going to have a good model outside the human, an in vitro model? Now, there were mouse models, but they don't have the classic airway disease, and the pigs and the ferrets weren't available at that time. So a whole program was developed to get human bronchial epithelial cells from bronchoscopies. And samples were sent in from different patients around the country. So again, it was a CF community working together. And it showed that in these cells, you got a nice response. And they could actually look at doses and decide what dose were you going to need in human beings. Then we come to the third step, and this was the scariest step. And I actually was peripherally involved at this time, and that is, how are we going to know it works in a human being? So the first thing you're going to have to do is, how are we going to have a biomarker that shows us that that salt that moved in a patient's cell in a petri dish is going to actually work inside them? And so after a lot of discussion, it was decided to use nasal potential difference, which Scott mentioned, which is measuring salt flow in the nose. And then Frank Accurso said, I think we need to look at sweat chloride. It's the oldest test we have, but it measures salt movement. So we looked at both sweat chloride and MPD, and it was this dramatic effect. So we had been able to move from a laboratory model to a human and use this as what we call a pharmacodynamic endpoint, so we could do the dose escalation. And then the final thing was, it changes sweat chloride. Does it help a human? And we chose FEV1 as well as other markers, and sure enough, it had a dramatic effect. This whole package together, along with a lot of safety and manufacturing work, and it was a full package that was rapidly accepted by not only the FDA but the EMA. So we accomplished the most important thing is this drug is now out there and available to people. So I think we all need to congratulate ourselves on this international effort that has made this pathway possible. It will make it much easier for the development of future drugs. But like any perfect story, there are always twists and turns. And we had hoped, seeing that dramatic change in sweat chloride and the dramatic change in lung function, that they would perfectly correlate. So you just get a sweat chloride and that would tell you what the lung function change was. But as this article shows you, this was actually written by a group from the FDA, is that there isn't a one-to-one correlation. so that some patients can have a dramatic change in one and not the other. And as Scott mentioned, it's because there are probably other modifying genes or environmental factors that have an influence here. We also know from the lumacaftor-ivacaftor story that sweat chloride change is much less dramatic than actually what they're seeing in lung function. So what it tells us is, as we move forward, we can start with the pathway, but each development is going to be a tributary of its own. And from each of those, we will learn and will grow. So how much have we accomplished? Well, as Dr. Bell told you, over 1,000 patients are now receiving ivacaftor, and that is fantastic. But unfortunately, that's only 4.4% of the patients, and we have over 95% remaining. So are there other people that can benefit from ivacaftor as a single therapy? Actually, there are several studies going on. One is looking at other class 3 gating mutations, looking at the little tykes, the infants and toddlers, and then other mutations such as R117H that have a little residual CFTR function. So for the gating mutations, a lot of those laboratory models, like the HBE cells, were used to test other gating mutations, and those in vitro studies showed that most of the gating mutations responded like G551D. So now they have been studied in the connection study, which was an 8-week placebo-controlled blinded crossover study, which has been completed. And you can see there that at 8 weeks, there was a 10.7% absolute change, which is almost identical to what was seen with G551D. And that result is so encouraging that Vertex has sent in a supplement to their NDA to get approval for all gating mutations. Now, for the young toddlers, really what needs to be done is a pharmacokinetic study to see what dose does this group need, and a safety study. And also a pharmacodynamic study with sweat chloride. And so the kids 2 to 5 years of age have finished the PK study, and now they're in the open label extension. And it's for all the gating mutations, not just G551D. It is fully enrolled, and the results are expected in the second quarter of 2014. Third, we have R117H mutations, and this is called the CONDUCT study. And this is a multi-center randomized, double-blind, placebo-controlled trial where ivacaftor is being given for 24 weeks. It's very similar to the phase 3 trial. But these are patients that have at least one copy of R117, and it's 6 years and older. This study is also fully enrolled, and the results are expected, hopefully, by the end of this year. So if we can add these 3 groups to G551D, you can see that we go up to almost 7% of the population being covered. Now, to make a huge impact, we need to move to the class 2 mutations. And as you probably remember, these are the mutations that don't get up to the cell surface. The protein misfolds and then gets broken down by the quality assurance system in the cell. Here you see a picture of a patient with F508, 2 copies. These are human bronchoepithelial cells, which I mentioned before. And what you see is the cilia at the top, and then the nuclei, and then the CFTR is that sort of green haze there in the cell. That's not where it's supposed to be. Now, again, F508 dominates the class 2. That's why class 2 is so important. In the US registry, and this is fairly true worldwide, F508 homozygotes are almost 50% of the patients. In addition, another over 10,000 patients have 1 copy of F508. Now, please see this 5% up here. Their other copy is G551D or R11H, so they may respond to monotherapy. We still have about 10% remaining. Very encouraging, through the same high-throughput screening process that I just showed you, Lumacaftor, which is also called VX809, has been developed. And although correctors have been a little bit more challenging, this has been a very promising product. And what it's shown to do, and this slide was provided to me by Fred Van Goor, you see now that that green in the cytoplasm has moved up to the airway surface. It's a very clear green band. That's what we want to see, trafficking to the surface. The other thing that's important to remember is that F508 or class 2s are also gating mutations as well as trafficking mutations. So if you look here at baseline, there's a tiny amount of chloride transport. If you add Lumacaftor, you get about a 14% improvement. Now this dotted line is our famous 30%, and we got a ways to go there. If you go over here, you see adding a potentiator, you're getting up to about 25%. So you're getting much closer to the bar. So combination therapy is necessary. Now here's the phase 2 study that was finished last year, combining Lumacaftor with Ivacaftor in patients that have 2 copies of 508del. You see that Lumacaftor alone had no impact and may even have had a slightly negative impact on lung function. But once the Ivacaftor was added, there was a dramatic improvement in FEV1. This shows us that this has to be combined therapy, and it obviously was a very encouraging finding. So with that finding from last year, 2 enormous phase 3 trials are moving forward. You now know that over 1,000 patients have been enrolled across the world in these 2 studies, which are called Traffic and Transport. They're looking at 2 doses of the combination of Lumacaftor and Ivacaftor, and those 2 doses are being compared to placebo. It's a 24-week study, and then it will roll over into a 96-week open label extension. The primary endpoint is FEV1. At 24-week point, it's a relative change in FEV1. And there are lots of secondary endpoints that you can see there, from weight gain to quality of life and pulmonary exacerbation. This study enrolled well ahead of time, and that's because of the incredible work of every person in this room. And because of that, the data is anticipated to be out next summer. So we have some really good news with CFTR correctors. There has been significant progress in patients who have 2 copies of F508 mutations. But with every advance, there are always challenges, and the great thing about the CF community is we love challenges and we fight them. So correction is a multi-step process. Scott started to show you this yesterday, and so it won't be surprising if it requires more than 1 drug. The other thing is, if a patient only has 1 copy of F508 and the other mutation, say for example it's a class 1, is not responsive to a potentiator or corrector, the clinical response is reduced. The CF Foundation realized about 4 years ago that the first generation of correctors might not be a slam dunk. And so they reviewed the lessons from this first generation of correctors, and they started creating a roadmap for getting more robust second, third, fourth generation compounds. And they have been very lucky to get strong partners in place. And you see them coming up here on your screen. So At least 7 companies are working on this, and also the foundation has its own laboratory in Boston. There's been amazing progress. They've been developing novel screens to test these correctors, and there are more than 6 million compounds that are out there available, either have been screened or available to be screened. So I just wanted to show you, this is the only basic molecular biology I'll be showing you, but you need to remember that CFTR has multiple components. It has the membrane-spanning components, which are shown as M, and those make up the channel. And then you have the nuclear binding folds, and there's also a regulatory domain, which is not on this graphic. But basically, each of those separate compounds has to fold, and then they have to attach to assemble the program. Remember what you saw yesterday with the balloon man. So that's really what's going on here. And I'm just going to blow up the interaction between the M regions and the nuclear binding folds. And you see on N1 that F5, that's where F508 is located. Now, having it there makes that a little bit unstable. But the other critical thing that we now know happens is that there have to be linkages made between the membrane spanning regions and the nuclear binding folds, and they're called cytoplasmic linkages, or CLs. And CL4 is particularly important. It's between N1 and M2. So now we understand that there are these multiple processes, and we may need to hit multiple sites. There is a phenomenal paper that came out this year. There's been work by multiple labs across North America, and this one came out. It has work from Dr. Verkman's lab, Dr. Lukak's lab, Dr. Thomas. I'm sure I'm going to miss names, but this is really a community effort. And what they have found, as Scott mentioned, is that there are multiple targets. Now, Scott called them classes. I refer to them as targets because I didn't want to get you confused with the functional classes. So target 1 is looking at the NBD1 itself and trying to stabilize it. And there are a lot of chemical chaperones that can do that. Unfortunately, those can't be used as drugs, so that may be an approach in the future. Another important area is that CL4 binding between N1 and M2. Now, it's believed that that's where VX809 and VX661 are probably working. In addition, there's a third target, and that's actually at the NBD2. And so even though 508's on one, it destabilizes everything around it. So that's another target for potential drugs. Why do we care? Well, this is an incredibly important slide, and it comes again from HBE cells. And here are patients, these are from patients who had 2 copies of delta F. If you look on the left, you have untreated. Then you get the combination of ivacaftor and lumacaftor. I already showed you that, getting up 25 to 30%. But then look what happens if you add a second corrector. It's more than additive. It throws us well over the 30% mark, up near 50 to 60%. And in the lab, with the 3 targets, they could get up over 80%. This is a major jump. And even more exciting is what I'm going to show you now. And this is a patient who has only 1 copy of F508, and the other one is a class 1, and so that's not responsive to potentiators and correctors. And you can see that the response with ivacaftor and lumacaftor is less. It's probably barely 10%. But then you add this second corrector, which is working at a different site, and all of a sudden you're getting up in the range of the 30% function. So I think this could potentially be a huge step forward. Now, if we do cover all the class 2s, we've covered almost 90% of patients. One of the major groups missing are the nonsense mutations, or class 1. The nonsense mutations are at the very beginning of translation of the gene into a protein. And what you see here is there's supposed to be a code at the very end to tell the ribosome to stop making a protein, so you get a full-size protein. But unfortunately, a mutation causes that stop very early. So what happens is you get this little shortened protein that's not functional. And they have been looking for compounds for well over a decade that can read through or go past this mutation and make the full protein. And the compound that's come the farthest is PTC-124, developed by PTC Therapeutics, also called adalurim. Now, the original laboratory studies were done in collaboration with the University of Alabama. And this is a rat model. It was a transgenic mouse that had a stop mutation, G542X. And what you see on the left is the rat intestinal mucosa where there's no CFTR at the surface. But once it was corrected with the adalurim, all of a sudden that red staining is an antibody against CFTR. You see this bright red staining because the CFTR has come to the surface. They then did some chloride transport studies called short circuit currents, and it went from no chloride activity to that uptick, which shows chloride activity. And that was so promising that a series of phase 1, 2, and even a big international phase 3 study was finished last year, and it was actually presented by Mike Constant at the European meetings. And you can see here that FEV1 was the primary endpoint, and there appears to be some effect, but it didn't reach significance, so it didn't reach the primary endpoint that they'd hoped for. But predefined in the analysis, they decided to look at those patients who were on inhaled aminoglycosides, and that's predominantly tobramycin, and see if there was an interaction with the adalurim, because they knew from laboratory models that these two could interact with each other. I forgot to mention, but aminoglycosides can do read-through themselves. So the patients who were not receiving aminoglycosides had a 5.7% effect, which was significant, whereas the ones who were receiving drugs like inhaled tobramycin had basically no effect. So it was a rather dramatic difference. For this reason, PTC has gone back to the drawing board, and they're going to be initiating another phase 3 efficacy and safety trial in patients who are not receiving inhaled aminoglycosides, and this will start in 2014. The CF Foundation is very interested in moving forward with other possible compounds in this class 1 group. They've initiated new discovery programs with both academic and industry partners. They're working with University of Alabama. This has long been an area of expertise for that group, and the Southern Research Institute, which is in Birmingham, to screen approved drugs to see if they have read-through capability. And there's also a group in France led by Elizabeth Sermet, where they have a very unique group of patients that have 2 copies of Y112X. Now this is a nonsense mutation that does have a slight amount of read-through, and so it's very susceptible to aminoglycosides. So they're looking at the effect of topical gentamicin in nasal epithelial cell cultures. Okay, here's where we are. Looks a lot better. So if we can cover the class 1, 2, and 3 mutations, either on both allele or one allele, we are covering over 90% of patients. But then you have this pink group over here, and you have the white group. And those are either we haven't identified the mutation, so we don't know what they'll respond to, or it's not covered. We cannot be satisfied with this. But there's something I really want you to see here. And that is that there are 1,768 patients in the registry that have no identified mutations, and then the rest of these have only one. That is not acceptable. We should have as our goal that 100% of patients have 2 identified mutations. And at this meeting last year, the mutation analysis program was, or MAP, was discussed. And in that, genetic testing is provided to U.S. patients who do not have 2 identified mutations. Now, I will say our center has worked very hard to get all of our patients, what we call mapped. But I would ask all of you, if you are not working on this or not knowledgeable about it, to go online to cff.org to find out more. The other program that was started about the same time, which is really, really cool, is CFTR2. Now, this is in collaboration with Johns Hopkins, as is the MAP program. And here is a website. It has lots of different aspects, but one of the coolest things is their website, where you can go and look up, I think they have 160 mutations, and where there's clinical data, you can find out about your combination of mutations. This one happens to be someone who has R117H and F508. Tells you what's the likelihood of having pancreatic insufficiency, what's the FEV1. I can't tell you what a wonderful teaching tool this is for parents and families and residents. My teaching evaluations have skyrocketed since I started using this. What about the rare mutations? There's always going to be mutations that don't fit nicely into those functional classes. And yesterday, Scott talked about some wonderful laboratory models. The intestinal organoids, remember they swell up with CFTR function, and then ROCK kinase inhibitors. So there's lots of neat laboratory models that may be used where you could take a sample from the nose or the rectum and test drugs in the laboratory. But eventually you got to test it in the patient. And so here's a model of a study design that could be used for rare mutations. It's called an N of 1 trial. It's a single center randomized double-blind study where each patient serves as his or her own control. So you take drug X, that I show you there, and you put them blinded. They have a cycle on drug, they're off for a while, and then they have a cycle on placebo. You don't know which you're on, but you cycle on both, and then you see what's the difference in response, and then you can go to the active drug. Now, right now, the primary endpoint that we would probably consider is FEV1, because that's really our primary benchmark. But as we move forward, as we get better assays, we might find a serum biomarker that we could use for a screen. We might use mucociliary clearance. So really the sky's the limit here. I do need to acknowledge that Vertex is currently using this approach to study ivacaftor response in very rare mutations that have residual CFTR function or splice variants. And this study is actually fully enrolled in Denver. Ultimately, if we're going to get to 100%, we need to think about non-mutation specific therapies. And when we started out, we were looking at gene replacement therapy, and that is still being actively pursued. And please remember, it doesn't matter what your genotype is for gene therapy. There's also work in gene repair, where you actually would have a technique, you go in and repair the gene where it sits, mRNA replacement, and protein replacement. Today I'll only have time to give you one example, and that's an excellent example. It's our colleagues across the pond, the UK Cystic Fibrosis Gene Therapy Consortium. They have been actively involved in a study looking at CFTR packaged in a liposome given by a nebulizer in 5 cc's of saline solution, and then it's compared to placebo, which is the saline. Patients receive 12 monthly doses. Patients have to be over 12, and the diagnosis is CF. You see there's no reference to what mutation they have. Primary endpoint, FEV1. So far, it's completely enrolled with 123 patients. And what's exciting is that the results will be available next autumn, maybe here at the conference. Do we need to go beyond CFTR? Do we still need to treat the symptoms of CF? I showed you this at the beginning. Do we need to prevent going to that blocked, inflamed airway? Absolutely yes, because we're giving these CFTR modulators often to patients who already have lung disease. Their lungs already look like this, and it's not clear we can reverse that. So we have to have other therapies. And we have to prevent organ damage, and we know now that that starts very early. So until we can get these therapies down to infancy, we need to have other treatments. There was an article that came out this year in the New England Journal from the Australian group. They have done these phenomenal studies called ARREST-CF of doing BALs and CT scans in newborn infants. And in that, they show that in the first weeks to months of life, you already have structural damage to the lung. That is very sobering, and that's why we have to keep moving forward. So you've seen the CF pipeline, and I wish I could go over everything on it. We have gone through the CFTR modulators, but today I'm going to focus on anti-infectives and anti-inflammatories. I do want to note at the bottom, see cff.org and clinicaltrials.gov. If you go to those two websites, you can find out about almost every CF trial, and I would encourage you to do that. Antimicrobials. Well, Pseudomonas aeruginosa has certainly been our major focus for the last 3 decades. And what I'm going to show in this one slide is over 20 years of work by clinicians, patients, scientists, and our fabulous industry partners to develop treatments for PA. We started with inhaled tobramycin, was approved in the late 1990s. That was a very exciting program for me personally. And then in the early 2000s, we looked at a whole different model, macrolides, which probably has as much anti-inflammatory effect as an anti-infective effect, but shown to have a dramatic impact on pulmonary exacerbation rate. And then in the last 5 years, things have really picked up. As Trionam for inhalation was approved, that's Cstr. In Europe, a dry powder cholistomethate has been approved. And then just in the last year, a dry powder formulation of tobramycin, but Toby Podhaler has also been approved. So we have, but there's more. I feel like an infomercial here. There's more because there are 2 phase 3 trials. One has been completed looking at inhaled levofloxacin, and a second, a multi-cycle study of liposomal amikacin for inhalation in 206 patients. So those are also potential new therapies soon on the horizon. And finally, there is a study comparing alternating Cstr and tobramycin versus just alternate month Toby. Because I don't have time to go into this very important area, I just want to refer you all to the symposium that is right after this plenary session. And Felix Ratchin will be talking about what have we learned about recent antimicrobials, and he will discuss this in more detail. One problem with our anti-pseudomal and antibiotics in general is we haven't really come up with antibiotics, this is worldwide, not just CF, with novel mechanisms of action. And so we've got to look at new approaches. And so here's just an example of a novel target, and it's gallium nitrate. So bacteria have to have iron. They need it to grow, they need it to be happy, they need it to make biofilms, which are their communities. Gallium is exactly the same size as iron. And so it can slip into the cell, replace iron, and it completely disables the bacteria. Gallium also is FDA approved for a totally different indication. But laboratory models showed, and this was provided to me by Pradeep Singh, and these are examples, these are photomicrographs of biofilms, and you can see that green staining is living cells, red staining is dead cells. And the gallium kills the cells in the inside of the biofilm, whereas tobramycin on the outside of the biofilm. So you can see here where this could be a complementary function. So the question is, can it work in vivo? And there's just been an early phase 1 trial of IV gallium, because that's what's approved. And at the higher dose, 200 milligrams per meter squared, it got excellent sputum concentrations that clearly were inhibitory of biofilms. And you can see that there was a significant improvement in lung function at 14 days. This is promising enough that now it will be going forward with phase 2 trials jointly funded by CF and the NIH and the FDA, excuse me. So I talked a lot about Pseudomonas, but we need to think about other bacteria. This was a very nice paper written by John LaPuma where he talks about progressing on our knowledge about bacteria. So we start out detecting them. Then the next thing we have to do is epidemiology studies to figure out, is this harmful or not? For example, S. multifilia, for years there have been discussion, does it impact health disease? And then you need to go to experimental interventions to try and get better therapies and finally change management. Now, with Pseudomonas, we've done that whole pathway. But unfortunately, for most of our other pathogens, we're way back in the line. And today I'm going to use 2 examples, Mersa, or methicillin-resistant Staph aureus, and non-tuberculous mycobacterium, because we are developing treatments in those areas. So let's start with Mersa. So Mersa has become more common in the United States in general, and it can be as high as 25% of patients in some sites. And again, a lot of discussion was, is this more harmful than standard staph, which is susceptible to methicillin? But there was a very nice study done by Elliot Dazenbrook a couple years ago where he looked in the registry and looked at 20,000 patients and looked at whether they'd had Mersa or not and looked at their survival over the average length of follow-up was 7 years. And you can see here that the positive patients are dropping off in their percent survival. In fact, the survival difference was 6.2 years. So this, I think, made us stand up and say, I think we need to look at other therapies for Mersa. And so there are 3 Mersa studies currently ongoing. The first is looking at eradication of initial Mersa, and this is called STAR-2. It's being led by Marianne Mullenbach and Chris Goss at 14 U.S. sites. Now, why initial infection? Because in that Dazenbrook study, it showed that if you were colonized for less than a year, it didn't have an impact. It's only when it became persistent. So if we can get in there and clean it out soon, that would be important. There's a second study that's looking at eradication once you have established Mersa, and that's being led by Elliot Dazenbrook and Mike Boyle at 2 sites, and they're testing inhaled vancomycin with oral antibiotics to see if it's efficacious. And now we have a sponsor who wants to get into the Mersa field, and they've developed a dry powder inhaled vancomycin called Aerovanc, and that's also currently in studies testing sputum density and lung function. All 3 of these trials are open and looking for patients. So, as I said, go to cff.org. Non-tuberculous mycobacterium, very prevalent also, ranges from 13 to 23% across CF worldwide. 1,000 times more common in CF than it is in the normal population. And it's so common that now annual screening has been recommended. Unfortunately, you need a sputum, so it would be in expectorating patients. The most common species are 2. Mycobacterium avium complex, or MAC, which is 2/3 of the patients, and the other third is M. abscessus. What impact do these have on patients? We know that patients who have symptomatic disease have very characteristic and very striking changes on high-resolution CT with nodular bronchiectasis and can have cavitary disease, not unlike their second cousin, tuberculosis. The M. abscessus have more rapid decline in lung function. Treatment. So MAC is interesting because some patients are totally asymptomatic with MAC and probably don't need treatment. But the ones that are symptomatic, there are multiple drug regimens that appear to be fairly efficacious. Unfortunately for M. abscessus, there is no drug regimen currently proven to be effective, and that's alarming. So we have a partner now that is trying to study this population with liposomal amikacin for inhalation. It's Insmed Corporation. And they have a phase 2 study going on, and 90 patients have already been enrolled, so enrollment is completed. And they're taking patients who have failed other therapies. They can either be MAC or M. abscessus, and they are both CF and non-CF. And if they've failed 6 months of therapy, then they either add this LAI or placebo. And we're hoping in the next few months the results of this will be out. The primary endpoint is reduction in density of the bacteria. So now I'm going to move on to inflammation. Now this is a picture of an airway, and you see all those mini black dots. Those are neutrophils. There's almost no infection that has the density of neutrophils that CF has. It's just massive sheets of white cells. And how do we control this? Now, these next 3 slides I stole shamelessly from Mike Constant from one of his plenary sessions. And what you see here, this is a normal lung. Now you remember that our lungs have to inhale gallons of the outside world, which have bacteria and toxic agents in it. So it's not surprising that the lung has set up a very highly complex and redundant inflammatory system to fight these intruders. And it involves multiple cell lines, lymphocytes, neutrophils, macrophages, and then you can see there are all these cross signals between them to turn them on. Now let's look at the CF lung. And now this is a CF lung before it's infected. And what is well known is even without infection, the CF lung is what we call pro-inflammatory. It's turned on, particularly pro-inflammatory cytokines such as IL-8. You have increased neutrophils, and their byproducts such as elastase. Again, the study I told you about from the Australian group that came out this year, they found that at 3 months, the infants, they may look perfectly healthy, they had elevated neutrophil elastase. And that predicted what scar tissue damage they would have at 1 year. 3 months predicted what was happening at 1 year. Tells us how important this is. Now all we have to do is have bacteria come in and get it infected. And this system is totally set up to say, bacteria incoming, we have to do something. And so there are these toll-like receptors that then upregulate a massive amount of genes, and all of a sudden, everything goes crazy. I'm not going to go into all these details. I don't think I'd understand it all myself, but what's important to see here is twofold. It's so intermeshed and complicated that if I decided I was just going to try to reduce IL-8, it's just going to go around it. If I decide I'm going to increase IL-10, which actually cools down the reaction, it's going to go around it. So that's been the problem. So then the other choice is, well, let's just wipe out everything. But these people are fighting infections, so we can't wipe out everything. So we have this very, very difficult balance. So far, we've had one proven efficacious therapy that really has, been shown the test of time, and that's high-dose ibuprofen. It slows the decline of FEV1, and long-term it's been associated with improved survival. So unfortunately, the uptake of it hasn't been as great as we would have thought because, you have to follow levels and it has side effects, so there's downsides as well. So there's been huge efforts to try and look at other potential anti-inflammatories. As I said, it's a very complex, redundant system. And the other thing is our endpoints probably aren't right. When you think about it, our clinical endpoints were developed from our very first roadmap, which was anti-infectives, inhaled anti-infectives. That's what it was developed for. That's probably all wrong for anti-inflammatories. The timeline here is much longer. The biomarkers are different. Neutrophil elastase is clearly a key player, but it really hasn't yet been a validated biomarker. And so studies of several low-hanging fruit or approved therapies just have not been successful. But we're not giving up. So what are the next steps? So there are some other novel therapies that are currently being tested. I'll just give you two examples. One was actually initially thought of as an anti-infective. It's a monoclonal targeting Pseudomonas type 3 secretion pathway, but it seems to have a very directed anti-inflammatory effect, obviously in patients colonized with Pseudomonas aeruginosa. That's being developed by CalBios, and the product is KB001A. There also has been long-term interest in alpha-1 antitrypsin because that is nature's way of sopping up all that elastase. And when you can't sop it up anymore, then it works its way down into the support structure of the lung and causes structural damage. And so Grifols Therapeutics is now developing a phase 2 trial of alpha-1 antitrypsin. But in addition, the CF Foundation, just like they've gone back and done strategic planning for everything else, they're launching in 2014 a strategic planning process for anti-inflammatories. We need to relook at this. We need to look at how will we screen them, what are our biomarkers, what are our clinical endpoints, so that we can move forward this program. So what I've tried to show you today is our incredible success. And it's going to continue that way. And that's because it's always been a worldwide effort. It's been the effort of patients, their families, the caregivers, scientists, industry partners, and foundations. But we're also looking to the future. And in doing that, we've made huge investments, not only in the basic research that you heard about yesterday, but for clinical research. As you know, I've had the honor of leading the TDN for 15 years, and we've also been able to work with the European Clinical Trials Network, which is doing a phenomenal job, and the Australian group as well. So these networks are now covering the majority of patients worldwide. And in addition, there's been a credible investment in registries. I've shown you data from the US registry, but there are registries across the world, and you see them. Now, I have to point out, I found out last night, the UK has 10,078 patients, so that's wrong. Did I get it right, Elaine? But overall, there are 60,000 patients in a registry. This is critical. We're getting all these new approved drugs. We're going to have to follow everybody long-term in what are called phase 4 pharmacovigilance safety studies. And so we've got to have them in registries so we know what happens for the safety of our patients. That's number one. Number two, we can't continue to do randomized clinical trials forever. We have to start comparing therapies, which is called comparative effectiveness research. And I will tell you, in the next decade, what you're going to be hearing on the podium is a lot of comparative effectiveness research. Do drugs work better alone or in combination? That is the excitement of our future. So Scott showed you this. He said this was a picture of his family. I thought this was Homer Simpson's family. And they said, "Are we there yet?" Well, I'm telling you, we are almost there. And so I'd like to thank you for listening to me this morning, and I also want to thank the patients and families who participate in our studies, the clinical sites for their hard work, and these following individuals who helped me enormously in putting this together. As Scott said, everybody is so generous about sharing their information. And a special thanks to Judge Van Devanter, who's here in the room, and Laurel Feltz, who put this together for me. So thank you.